Hi everyone, I am Letty and I did Chapter 5, Demand for Health and Medical Care. For the first slide, I have what is health and medical care. Healthcare or medical care is the maintenance or improvement of health via the prevention, diagnosis, and treatment of disease, illness, injury, and other physical and mental impairments in human beings. Medical care is the provision by which a physician of services related to the maintenance of health, prevention of illness, and treatment of illness or injury. Most people place high priority on their health and consider access to quality care essential to achieving their health goals. Medical care is one of the several factors that may be used to improve the health status of an individual or a population. The other factors that may be more important in producing good health include improvements in living standards, advances in medical research, changes in lifestyle, reduction in environment pollution, and better nutrition. There are other inputs that also are included in medical care that we will learn about as we move through this chapter. The demand for health. As most of us know, as Americans, we value health. This is evidenced by the fact that the pursuit of good health is a multi-million-dollar business. In addition to money spent on medical care, countless dollars are spent on health foods, fitness videos, gym memberships, and weight loss programs. As important as good health is to our overall well-being, it would be a mistake to conclude that every person considers good health the primary goal in life. Our day-to-day behavior undermines this notion. I say this because how else can we explain our overconsumption of food, alcohol, and drugs, along with risky behaviors like skydiving, bungee jumping, and driving a motorcycle without a helmet? There is also the question that if we want to be so healthy, why do so many of us smoke or do illegal and legal drugs? We have clearly seen on television and other media sources what smoking does to our body, and we also have seen what drugs can do to us, but yet many of us continue to do it. And also, many of us have seen My 600-Pound Life, and yet we continue to consume unhealthy foods at alarming portions. As we begin to think about the demand for health, our starting point will be the relationship between health and the factors that contribute to it. We'll begin to see how medical care is one of many inputs and how it contributes to improving our health. The production of health. In economics, the production of health is depicted as a functional relationship that shows how inputs are combined to produce an output. Specifically, health production function summarizes the relationship between health status and the various factors that may be used to produce good health. A simple way to consider is much the same way that teachers use books and resources to produce knowledge. Therefore, the amount of medical care spending increases, the health status improves, and we view the production function as a maximum health status that can be achieved at a given level of medical care spendings. Medical care spending is not the only thing that improves our health. Earlier, I showed some of the factors that affect our health, including lifestyle and environment pollution, but I want to also add technological developments as well. Measures of health status. Everyone has their own opinion on what constitutes good health. But we have to keep in mind that health is more than an absence of disease. The Constitution of the World Health Organization defines health as a state of complete mental, physical, and social well-being, and not merely the absence of disease or infirmity. But it is important to remember that the World Health Organization adopted the definition in 1946. And it is said that the drawback in using such a definition so broad is that the health and well-being depend on everything. Measures of health status continued. Some of the measures of health status include mortality, morbidity, quality of life, and quality of life. Mortality is one of the most common aggregate measures of health status and the crude death rate for a given population, and that is measured by the number of deaths per 1,000 people. For mortality, often the measure is adjusted for age, sex, and race in order to make measurable comparisons among subgroups across geographic regions or countries more meaningful. As for morbidity, an alternative way to measure health status is to consider the prevalence of certain diseases or medical conditions. Typically, morbidity measures include restricted activity days due to illness, the incidence rate of certain chronic conditions, and a self-assessment of health issues. Finally, quality of life. Some may view measuring health status as a nice academic exercise, but it is a deadly serious proposition for health policy planners. In a world of scarce resources, some means of resource allocation is inevitable. Responsible planning requires the actual scheme to be clearly stated and easily understood, and those responsible for the implementation should be accountable for their decisions. Effective resource allocation requires establishing a measurable output. Determinants of health status. Medical care is not the only factor that contributes to the production of health. Others include income and education, environmental and lifestyle factors, and genetics. Research on the relationship between health status and medical care frequently has found that marginal contribution of medical care to health status is relatively small. In other words, what they're saying is that any significant improvements to health status are more likely to originate from factors other than medical care, and the easiest way to improve health may shift to the production and function for health. Determinants of health status continue. Some of the determinants that were income and education, environmental and lifestyle factors, and genetic factors. For income and education, the link between an individual's state of health and socioeconomic status may not be direct, but the theoretical underpinnings are obvious. Income and education and employment represent a level of social advancement that to a large extent determines access to medical care, especially in the U.S. Employment determines insurance coverage to a great degree, in turn improves access to care and improves health. For environmental lifestyle factors, regardless of the level of income and education, health status depends to a large degree on personal behavior and personal discipline. These factors include diet, exercise, sexual behavior and orientations, cigarette smoking, substance abuse, and brushes with violence are important determinants in health status. Finally, we have genetic factors. There are two factors that play a critical role in determining health of an individual: the risk of exposure to a particular disease and recover from its consequences once exposed. Our genetic makeup is determined directly by our biological parents. We receive 50% from our mother and 50% from our father. This determines etiology of certain inherited diseases, for example, sickle cell anemia. This differs from causation of infectious diseases. The relationship between social, class, and health. Most of the research on health disparities across socioeconomic groups has centered on racial differences in health. There is no question that health disparities exist across race and ethnic groups, as seen in differences in the selected mortality rates. While race is important in determining health status, there is growing evidence that social class may also play an important role. Health might determine the social position to some extent. While it is plausible that unhealthy people migrate to poor neighborhoods, It is unlikely that these migratory patterns are the sole reason for the observed differences. Lifestyle may be important, but that begs the question, why are socioeconomic differences in alcohol and tobacco use, physical activity, hypertension, diabetes, cholesterol, and obesity? The social gradient indicates that everyone is affected, regardless of the socioeconomic status. The role of public health and nutrition. Public health providers across the spectrum, from individual physicians to community clinics and hospitals, are realizing that treating food insecurity and poor nutrition as a health issue can lead to better health outcomes for patients, improvements in community health, and cost savings. Increasingly, nonprofit hospitals are engaging in the proactive work to address these food insecurity and nutrition, not only among their own patients, but more broadly as a part of their community benefit programs to promote population health in the communities where they are located. These programs are leveraging and increasing the impact of the U.S. Department of Agriculture, which is the USDA Food and Nutrition Services. They use our nation's core nutrition programs to address the food insecurity and to improve nutrition. Improvements in public health programs are responsible for much of the improvement in human lifespan experienced over the past century. The improvements also may do much to improve life expectancy in the less developed world than increase on medical spending. The relationship between nutrition, mortality, morbidity is so complicated. Better nutrition has played a significant role in the reduction of mortality from infectious disease, in particular childhood diseases to respiratory and intestinal infections. It's important to remember that the increased availability of medical care is only one way to improve health status of an individual or a population. In the developed world, at least better lifestyle decisions and cleaner environment may do more to improve health than increased availability of medical care. However, in the least developed world, better sanitation, potable water, and improved living conditions top the list. I also included the table 5.3, which is the age-adjusted mortality rates by sex and race. This table was done back in 2010, and what they wanted to prove was the selected causes of deaths per 1,000 people. The major differences that I noticed here, and this is between white females, white males, black females, black males. They don't have the Latino community included in this or other races. They have heart disease for a white male is 222.9 per 100,000 deaths, where a black male is at 280.6 per 100,000 deaths. That is a significant difference for me, I thought, for that. Also, cancer for a white male was 208, where a black male was 264 deaths. And that was very, very significant. And two other ones that I wanted to name out was homicide for a white male was 4.7, for a black male was 31.5. Those are staggering, significant differences in deaths of homicide. And finally, suicide for a black male was 9.1 per 100,000 individuals, but for a white male was 22. I thought that was a big, big difference there as well. The demand for medical care. As medical care spending continues to escalate, the search for alternatives to slow this growth has focused on the supply side of the market. Modifying provider behavior is seen by some as the only way to control runaway spending. By ignoring this side of the market, we may be foregoing one of the most powerful forces available for cost control: individual self-interest. A basic understanding of the demand side of the market is an important step toward fiscal responsibility in medical care. And remember, the most powerful force for controlling medical spending is the cost-conscious consumer, which would be us. Medical care as an investment. One demand-side approach treats medical care the same as the other investment that enhances future productivity. In economic terms, medical care increases human capital. Resources used to improve health reduce current consumption, resulting in a decrease in the amount of money available to spend on items other than healthcare, with the exception that future consumption will increase because of the availability to work longer and earn more money. Individual willingness to invest in health improvements is determined by several factors: the current cost of medical care, the size of the future payoff, and the time span over which the payoff is realized, and individual time and preference. The same individuals who are willing to spend the money on college tuition are the same people who are willing to spend money to improve their health. Therefore, the association between health and educational attainment is significant. Factors influencing demand. The demand for medical care is determined to a great extent by patient need. Admittedly, need is a difficult concept to define, but the one thing is certain: need and demand are not synonymous. Needs tend to be self-defined and therefore represent unconstrained desires. Defining medical care demand in terms of self-defined need is a prescription for wasting medical care resources. As a society, we can never fully satisfy unconstrained desires. In economics, demand is defined in terms of the sacrifice an individual is willing to make in order to obtain a given amount of a particular good or service. Society is unwilling to allow anyone to fall below this minimum threshold, and this minimum level will vary depending on the individual's current health status. Individuals with acute or chronic health problems will require more medical care. Other factors influencing demand continued. Some of the factors that are influencing demand are patient factors, health status, and demographic characteristics, along with economic standing and physician factors. Patient factors influence demand because with medical care, as with any other commodity or service, consumers must decide among the available alternatives designed to satisfy their desires. For the demand relationship to have any economic meaning, patients must have money to spend on treatment alternatives and the ability to rank them in order of preference. Health status is when a patient is seeking treatment for a medical condition typically initiates medical treatment. The patient's desire for medical treatment is often a response to an accident, an injury, or an episode of illness. The demographic characteristics include individual and population demographics that are also important determinants of medical care demand. First of all, a growing population will increase in demand for medical care. Even as the population grows, the family structure is changing dramatically, increasing demands on the medical care sector. The economic standing influences demand because in the U.S., education, income, and medical care spending have always been closely associated. And historically, individuals with higher income demands more medical care. And more recently, the importance of income determining medical care demand has diminished with the increase in third-party insurance coverage. Finally, the physician factors influence demand even though only 20% of all medical spending goes directly to physicians. The decisions they make are responsible for the majority of the total spending. That physicians prescribe drugs, they admit patients to hospital, and order tests. Their influence on demand stems from the physician's dual role as an advisor for the patient and the provider of the services to the patient. Measuring demand. Hundreds of studies have attempted to measure the impact of the various factors influencing the demand for medical care. Early research focused on the differences in utilization between individuals who had health insurance and those who did not. But there's so many variations and differences in income and insurance coverage. Even time cost measured by hourly wage was also affected in the demand for medical care. Summary. The demand for medical care is derived from individuals' desire for good health. Accessing medical care is only one number of ways that individuals can improve their health. In fact, when the other factors are taken into consideration, the marginal contribution of medical care is relatively small. The contribution of environmental, lifestyle, and genetic factor weighs heavily in determining overall health. Economic factors do matter in determining the demand for medical care. So let's be careful how we use these incentives. My question to you is, what kinds of things do you recommend we do in order to help minimize the factors of influencing demand in our healthcare system? I want to thank everybody for watching my presentation. I hope I did good. I appreciate learning from you guys, and I will see you later. Bye-bye. Thank you.